Evet, Recep Bey'e de teşekkür ederim.
Thank you very much. It's a bit of an unlucky session, this session. We first started with some problems, technical problems. So let's get it back together. And those who have more than 5 obsessive compulsive disorder, could you please raise your hands? I want the Turkish version in front of me, if we can. So maybe one Turkish, the other is English. I'd be very glad. Thank you.
Şimdi ben arkadaşların çoğu genç. 94'te ilk
The first obsessive compulsive disorder clinic was established by me. I know that, and we were together with many colleagues. I'm a little bit older than the rest of the population, and then we didn't have that much of a clear idea with regards to OCD. We have established the clinic, and then we started improving ourselves, our knowledge as well. You know that there are repetitive, recurrent ideas and recurrent impulse or impulsive compulsions, and there is socio-occupational dysfunctionality as well. So OCD around the world has an incidence of 2 to 3%. It's the same in Japan, it's the same in Spain and Italy, where people are much of stress-free there. So there is no difference in terms of its prevalence. And 40 to 60% of OCD patients are not responding to SSRIs. So there is no improvement. And the scale score points do not go down. So this is the rate, 40 to 60%. And then we started some other additional studies. Olanzapine, risperidone, quetiapine, and aripiprazole drugs have been shown to be successful in OCD treatment. And 2/3 of these patients need this because, 1/3 of the patients need this because the other 2/3 is treated with SSRIs. And when we administer an antipsychotic, 1/3 is only benefiting from that. And then we administered it for 3 months. Then, if there is no benefit, it's not going to be beneficial for the upcoming months as well. But we also know that when we compare this with other anxiety disorders, the second generation antipsychotics are used more in OCD regime.
Travma sonrası stres bozukluğu ya da yaygın anksiyete bozukluğunda bu tarz bir güçlendirmeye
this is very important, therefore, to use these agents. And the second generation antipsychotics are used more now in OCD, but maybe metabolic complications due to this administration may also increase. That is why OCD and metabolic syndrome is very important, like hyperlipidemia, insulin resistance, and diabetes mellitus, and obesity. Maybe there is a link between these two. So we have to also observe that as well. As Recep also mentioned, and the prevalence of metabolic syndrome may differ from one gender to another. But when we look at South Asians and Europeans, the prevalence seems to be the same. But NCEP adult treatment panel 3 scales, with these scales, we have seen that 39.6% is the prevalency of metabolic syndrome in females, and it is 28% in males. This is interesting, this is important, because another data suggests that it is more in male population. I'm going to show that in a while. In Adana and in Gaziantep, the prevalence is higher. I mean, the waist circumference is higher. By the way, I am also coming from that region. I am from Hatay, so I'm trying to also prevent metabolic syndrome happening in me. In schizophrenic patients, the metabolic syndrome prevalence is 19-63%. In schizoaffective disordered patients, it's 42%. In bipolar, it is 24%. In repetitive depression, it is 12-36%. And in PTSD patients, it's 31-35%. So when we go back to the previous definition, we see that 1/3 is affected with metabolic syndrome. I was a chief clinician in Şişli Etfal Hospital, and we carried out a study in 2009. We have observed in this study that 36 OCD cases were reported in 2007 to 2009, and the mean age was 35. And I think the missing link in the studies around the world is that there is no mean age, by the way. Anyway, 15% or 15.9% is the metabolic syndrome prevalence. So the general population had 35%, but then 15% corresponds to this age. And then I changed my institution. I started working in another institution, and then we couldn't coordinate ourselves and our studies, but we were talking about making another study. But then again, there was this Italian study. The prevalence rate in that study was 21%. Use of tobacco, lack of physical activity, and high BMI was amongst risk factors. And then exposure to antipsychotics was also a risk factor for metabolic syndrome. It was suggested in this Italian study. Then there was this Turkish study we did for OCD and metabolic syndrome. Out of 70 cases, 12 had important serious diseases like recent MI and so forth. And there was obvious lacking or shortcoming in the cognitive scores. Between June 2009 to December 2009, we did this evaluation, and 44 females and 14 males were our sampling group, and 36 was the mean age. This age is the age that we do not expect to see a metabolic syndrome. And then we wanted to see other features as well, like gender, age.
IDF'in daha katı olanı değil de biraz daha
and comorbidities. NCP Protocol 3 was used. As Recep also mentioned this, I'm not going to go into the details of these, but as conclusions, we can say that metabolic syndrome was found to be 19% of all the samples. And the mean age of the participants in the study was 36. There was no statistically meaningful difference between the genders, but contrary to Metzar findings, our findings suggested that male population had more metabolic syndrome, but the male population also had an older age. So the sample group was predominantly women. 28% of the males were diagnosed with a metabolic syndrome, whereas women were diagnosed with, 15% of them were diagnosed with metabolic syndrome. So statistically, there was no difference, meaningful difference. But this was different then again in our findings. So these are the components of metabolic syndrome. Waist circumference, 104 to 91. Systolic blood pressure, 136 to 116. Diastolic blood pressure, no meaningful difference. Triglycerides, 192 to 133, which is significant, the difference. Fasting glucose, 102 to 80. HDL levels, statistically not meaningful. So they may not have a difference amongst each other, and this may be due to the age group. Gender, 19% is the total metabolic syndrome prevalence, 15% is from women, and 28% in male. This is a little bit different when compared to the general population prevalence. What about comorbidities? Depression, dysthymia, bipolar disorders, generalized anxiety disorder, panic disorder, social anxiety disorder. 82% of them were on SSRI, 13% of them on SNRI, 3% were on tricyclic antidepressants, and 44% were on AAPs, and 5% on TAP. By the way, of course, some of them were on various drugs as well. The mean age was 46, so the mean age for those with metabolic syndrome was 46, and those without the metabolic syndrome was 33. So as the patient goes older, of course it's more easier for them to have a metabolic syndrome in OCD, so this is different in schizophrenia and bipolar disorder. So if you're going to augment the therapy, if you're going to follow an augmentation therapy, maybe this is something that you have to take into account. Comorbidities and drug regimes. Here you can see that the differences here are also not meaningful. So the drugs that you use, a p-value is non-specific, so there is no difference. And typical antipsychotics were very few in this sample group, but as you can see that there is no significant difference between these groups. This is only for OCD, by the way. This is atypic metabolic syndromes. Those who are on atypic agents, this is metabolic positive, this is metabolic syndrome negative. So their waist circumference nearly the same, their blood pressure both the same, triglycerides both the same. The only difference is HDL. The higher the HDL, the better the people are. So in those that are not using atypics, HDL is a little bit higher. It's good. As Recep also mentioned, we have to have a holistic eye, of course, but if you are making your patient start an antipsychotic agent, here is the results for Canada, UK, Belgium, Australia, Mount Sinai. All of these do have serum values, and if there is a diabetes history in the family, we have to look at these parameters. You shouldn't ignore the history of the patient's diabetes history. So, metabolic syndrome can be seen in those cases with OCD, but it is less prevalent when compared to other psychiatric disorders. The age is itself a risk factor, and low HDL levels may be due to antipsychotics. When compared only those with or without metabolic syndrome, there is no difference, no meaningful difference between HDL levels and diastolic blood pressure. Of course, the main risk factor, the main criterion here is age, of course. Thank you very much for your attention.